Okay, so now we're going to move on to Rachel Caddy. So I'll just do a quick introduction of Rachel. So she's a King's College graduate, graduated with a postgraduate diploma in dietetics. And her current role is a highly specialist HPB dietitian in Liverpool University Hospitals. So her main passion is working with patients who have pancreatic conditions. In particular, you have a keen interest, I think, in pancreatic exocrine insufficiency, and particularly the education of pancreatic enzyme replacement therapy. Another keen interest of Rachel's is the prehab of patients with pancreatic cancer who are about to undergo surgical intervention and looking at the patient outcomes. You've done many presentations at national conferences and education with Viatris and Pancreatic Cancer UK. So without further ado, I will introduce your lecture, which is the state-of-the-art lecture this morning, and it's Pancreatic Enzyme Replacement Therapy, the when, the who, and how much.
Thank you so much. So hi, I'm Rachel. I am a specialist dietitian working at the Royal in Liverpool. I'm actually currently on maternity leave, so I've been rescued from the fog of motherhood to come and talk to everyone today, which has been fantastic, so thank you so much. I will see people with pancreatic conditions, so pancreatic cancer, severe acute pancreatitis, and our session today is talking about exocrine insufficiency and how to manage it. So exocrine insufficiency, a reduction of pancreatic exocrine activity in the intestine at a level that prevents normal digestion. So we know the pancreas has a hugely important role in the digestion and absorption of our nutrients. When we're getting a failure of that pancreatic exocrine function, what's happening is that we're maldigesting, we're malabsorbing, so we're leading very quickly to malnutrition. Now, those symptoms of exocrine insufficiency, early doors, very kind of non-specific. Bloating, nausea, abdominal pain. And it's not until we get to that kind of more severe exocrine insufficiency that we get in some of those more overt symptoms that we might be more familiar with. So steatorrhea, large volume, greasy, oily stools, difficult to flush away, very smelly. Large volume watery diarrhea, ongoing unexplained weight loss, nutritional deficiencies, especially of those fat-soluble vitamins. And the reason we don't see those more overt symptoms till later on is because the pancreas has a really large functional reserve capacity, meaning that we don't see those symptoms usually until the pancreas exocrine function is less than 10% of normal. So the impact of exocrine insufficiency, we're leading very quickly to malnutrition, which we know impacts on morbidity and survival, impacts on weight, lean body mass, sarcopenia, nutritional deficiencies, treatment tolerance, so that could be fitness for surgery, it could be tolerance of certain treatments like chemotherapy. Exocrine insufficiency adversely affects survival in chronic pancreatitis and negatively impacts quality of life in people with pancreatic cancer. So how do we diagnose? So the gold standard is coefficient of fat absorption. This is not used clinically because whoever is being tested for exocrine insufficiency, they would have a specific diet for 5 days containing about 120 grams of fat. For the last 3 of those days, all stool produced is collected and analysed. So it's not appropriate for a clinical setting. What we do see clinically is fecal elastase. So elastase is an enzyme that's produced by the pancreas, travels through the GI tract unchanged, and whilst it's produced only in small amounts, it's a reliable mirror of those other enzymes that are produced by the pancreas. So it's a good surrogate marker for exocrine function. The elastase is measured in the stool sample, and these are our cutoffs. So we've got severe, moderate, mild, and then normal. It does have some drawbacks. It's very reliable and specific for severe exocrine insufficiency, but for mild or moderate disease, it's less robust. And if the stool sample is getting some dilution, so if somebody has a large volume watery stool related to exocrine insufficiency, what we could see is that the stool sample is not appropriate for analysis, and it might give a false result. Despite this, it's a suitable first-line test for diagnosing exocrine insufficiency in a clinical setting. And then we've got the mixed triglyceride breath test. So again, not really used clinically. But this is, it has high accuracy compared to the gold standard. And essentially how it works is a labeled triglyceride is incorporated into a test meal, digested and absorbed. And during that digestion, the lipolysis, the free fatty acids and the monoglycerol are transported to the liver. And then the oxidation there of the label is releases labeled CO2 breath. So that is what we're measuring, the labeled CO2 in the breath. This correlates with the enzymatic action. So if you have fewer enzymes, we get less labeled CO2 in our breath. Again, not used clinically, but something really helpful for research. So some kind of more admittedly older data now, 2010, suggested more than 11,000 people develop exocrine insufficiency in the UK annually, related to pancreatic cancer for the majority, chronic pancreatitis, and cystic fibrosis. Some more up-to-date data from 2015 looked at exocrine insufficiency rates in primary and secondary care. So looking at kind of moderate and severe disease, we're seeing here rates of, rates of 20%. If we're just looking at severe, rates of about 12%. And then in secondary care, rates of 14% for mild and severe, and then just severe, about 8.6%. So we know exocrine insufficiency is there, it's just are we picking it up? So what's the mechanism there for exocrine insufficiency? So a loss of function in pancreatic tissue, pancreatitis, pancreatic cancer following surgery, or decreased secretion of pancreatic fluids, so enzymes, bicarb, maybe due to an obstruction. So if somebody has pancreatic cancer, that tumor might be obstructing that delivery of those pancreatic fluids. And then secondary exocrine insufficiency. The pancreas is working fine, but other mechanisms are interrupting. So postprandial asynchrony, impaired hormonal stimulation. And we're going to look at some of the conditions where we might see some of these mechanisms taking place. So we know we see exocrine insufficiency in pancreatitis. It's highly likely in people with chronic pancreatitis, reported in 94% of people following within 10 years of diagnosis of chronic pancreatitis. With our severe acute pancreatitis patients, we'll see exocrine insufficiency in about 66% on admission. This is more common in people who have severe acute pancreatitis, which is complicated with necrosis. Now, at follow-up, that rate has dropped there to 42% of exocrine insufficiency. So following that insult on the pancreas, as it's recovered, we may see some exocrine function regained. And in pancreatic cancer, again, we're going to see exocrine insufficiency in pancreatic cancer. There's damage to that pancreas tissue. And we've got some nice stats here looking at exocrine insufficiency rates pre and post-op, and for people who are inoperable. So if somebody is having a Whipple's, we might see exocrine insufficiency rates of up to 44% pre-op, increasing up to 78% post-op. A distal or left pancreatectomy, 20% pre-op, up to maybe 80% post-op. For a total pancreatectomy, 63% of people have exocrine insufficiency pre-op, and 100% post-op due to the nature of the surgery. And then locally advanced pancreatic cancer, huge range. You know, it depends how advanced the disease is. So we're looking at 25 to 100% of people experiencing exocrine insufficiency. But we need to think outside the box. Where else are we seeing exocrine insufficiency? So diabetes, insufficient production or resistance to insulin resulting in hyperglycemia. Now, if we think about physiologically about the pancreas, you know, those endocrine and exocrine functions are so closely linked that it makes some sense that they may be impacting on each other. So we're getting a wide range here, 14 to 74% of people with type 1 and type 2. So in a meta-analysis from 2016 of 3,600 patients, there was an increase in prevalence of exocrine insufficiency in people with diabetes versus controls, which was significant. And then within that, the people who had type 1 diabetes, again, more significantly likely to have exocrine insufficiency compared to type 2 diabetics. Now, in this analysis, duration of diabetes didn't impact on exocrine insufficiency severity. And then we have a multi-center study, again, looking at exocrine insufficiency in diabetes. Smaller numbers, 133 patients with diabetes, and the exocrine insufficiency rate was 13%. The authors admitted that was fairly low, and they didn't really know why. I thought maybe it was to do with better management of diabetes, but ultimately didn't really know why. Again, they found that increased with type 1 diabetics. And in this study, there was an association with duration of diabetes and exocrine insufficiency. Now, what I found interesting here was those people who had been diagnosed as having severe exocrine insufficiency using the fecal elastase test, these were all prescribed insulin. They were all on insulin. And that was compared to only 73% of people who had a more moderate diagnosis of exocrine insufficiency. So we're looking here at type 1 diabetics, length of disease potentially. How is that disease managed? And these are all risk factors that we need to look for in terms of thinking about exocrine insufficiency. Now, interestingly, in this study, with the fecal elastase, this was their initial screening with further investigation using that breath test that I talked about there. For the people who were diagnosed as having exocrine insufficiency from fecal elastase, with the breath test, it was normal, 100%. Again, they didn't really know why. They thought maybe it was due to the accuracy of those diagnostic tools, but it's something that needed a little bit more investigating. And what's the mechanism? So again, it's not fully agreed upon, but thoughts that maybe autonomic neuropathy is affecting pancreatic function leading to development of exocrine insufficiency. Organ size, so reduced size of organ will be associated with exocrine insufficiency, and there's people with type 1 diabetics have a smaller organ compared with people with type 2 diabetics. And a CNS cell atrophy due to the reduced trophic effects of insulin. So moving on, celiac disease. So our T-cell mediated reaction to gluten that causes inflammatory injury to the small intestine. A review showed that up to 61% of people with celiac disease who are treated on gluten-free diet have persistent diarrhea. And of these people, up to 18% of people have exocrine insufficiency. Now, in people who are newly diagnosed or untreated, they're not following their gluten-free diet, we might see exocrine insufficiency in up to 80% of people. But why? So malnutrition is associated with defects in pancreatic secretion. We know we see malnourished people presenting with celiac disease. But what I found interesting here is this defective postprandial response by the atrophic, the damaged upper intestinal mucosa. And this is impacting on a hormonal stimulation of the pancreas, altered synthesis, storage, secretion of secretin and CCK, and asynchrony between gastric emptying and gallbladder contraction. Now, a study from 2006 hypothesized that exocrine insufficiency with intestinal villus atrophy results from reduced pancreatic stimulation due to reduced CCK secretion. 24 subjects with celiac disease, 12 with cow's milk protein allergy, versus 62 in healthy controls. Small numbers and done in pediatric subjects. So of course, we have to think about our application to our adult patients. But what they found was for people following a gluten-free diet who are celiac, their CCK levels increase significantly postprandially. So healthy bowel, we see the significant increase in postprandial CCK levels, comparable to controls. Following a gluten challenge, with villus atrophy confirmed by jejunal biopsy, what we're seeing here is CCK level didn't change in people with celiac disease. And it did change compared to our controls. So we're not seeing any change there. And for fecal elastase test, they looked at their fecal elastase levels with healthy intestinal mucosa versus villus atrophy. So villus atrophy is here in white versus our normal in gray. And fecal elastase levels are significantly higher in normal mucosa with a healthy bowel. This was showing here that pancreatic secretion is impaired in patients with flat intestinal mucosa, postulated to be associated with that reduced intestinal CCK stimulus rather than damage to the pancreas itself. And because it was due to that villus atrophy, what we're seeing here is exocrine insufficiency in celiac disease is typically transient, and it's reversed with the gluten-free diet. So interesting. You're welcome. So moving on to GI surgery. So gastrectomy, whilst we're not taking away the pancreatic tissue, what we're changing here is the physiology, and that can impact on how well the pancreas is working. So a study here of 15 patients following gastrectomy due to gastric cancer showed that 100% of patients had exocrine insufficiency at 3 months. And a comparative study of fat absorption after Billroth and Roux-en-Y reconstructions following a subtotal gastrectomy showed that after reconstruction with both Billroth and Roux-en-Y, this resulted in an absorptive function reduced compared to healthy controls. But the Roux-en-Y reconstruction led to a significantly greater reduction in fat absorption. and esophagectomy. So 46% of people experiencing severe weight loss within 3 years, with intestinal malabsorption likely significant contributor to post-op malnutrition. And this systematic review here of 8 studies showed that exocrine insufficiency reported in 5 studies, and in 2 of those studies, severe exocrine insufficiency at 16 months, 16% at 4 months, 26% at 6 months, and then increased again further to 44% at 18 months. So it's there, and it's getting worse. And again, what's the mechanism? So this defective postprandial stimulation reduced CCK and secretin release due to the exclusion of the duodenal passage of food. So with that Billroth reconstruction, the food continues through the duodenum. With the Roux-en-Y, it's bypassing that, and this is where we're seeing some dysfunction. We're seeing asynchrony between gastric emptying and pancreatic secretion. You know, we're a well-oiled machine. If we're tinkering with those parts, it's not going to work as well. So we're getting inadequate mixing of nutrients with enzymes, and then disrupted neural stimulation of the pancreas during gastric surgery. If the vagus nerve is severed, then that impacts on the stimulation of pancreatic secretion. So exocrine insufficiency isn't the be-all and end-all. We have to think of it as differential. So small intestinal bacterial overgrowth, higher risk if somebody has a blind loop of bowel, gives similar symptoms, resolved with antibiotic therapy, or bile acid malabsorption. If those bile acids would normally be reabsorbed in the ileum, if they make it down to the colon due to impaired enterohepatic circulation, then again, we're going to see some of those symptoms very similar to exocrine insufficiency. Managed with bile acid sequestrants and a low-fat diet. So if we're thinking that exocrine insufficiency is the cause, then the cornerstone for treatment is pancreatic enzyme replacement therapy. Replacement of the enzymes that the pancreas normally makes. Now, we all have our first lines. We tend to use Creon 25,000s. We don't use 10,000 capsules where I work because it's a huge pill burden on the patients. And then we have other options, Nutrizyme 22, Pancreas V, which is our powdered version. Now, it's not a one-size-fits-all approach with pancreatic enzyme replacement therapy. You know, if we're looking here, I've highlighted our kind of first and second lines. So whilst Creon 25,000 has got higher units of lipase compared to Nutrizyme 22, Nutrizyme has got higher levels of amylase. So think about what your patients are telling you. You know, if we're getting some, overt steatorrhea, then what we might think about is whether we use an enzyme replacement therapy that has higher levels of lipase. Or if somebody's getting kind of bloating, wind, abdominal pain after eating, could be linked with malabsorption of carbohydrates. Would we use something that's got high levels of amylase? So think about what the symptoms are and have a trial of alternative enzymes if needed. So the management of exocrine insufficiency using PERT. So start your pancreatic enzyme replacement therapy. At least 50,000 units per meal, 25,000 units of lipase per snack, and titrate until your symptoms are resolved. Enzymes should be taken with all meals, all snacks, all nourishing drinks, milkshakes, milky coffee, cappuccinos, lattes, hot chocolates, and should be taken with all oral nutritional supplements, milk-based, juice-based, modular, because we need to optimize the absorption from those. Store at room temperature and swallow with a cold drink. We know extremes of temperature can impact on how well those enzymes are working. Take throughout the meal. There's some evidence to suggest that enzymes taken throughout the meal rather than all at the start or all at the end is more effective. And think about the composition of the meal. You know, if someone's having fish and chips versus a lentil salad, there's going to be a lot more fat in the fish and chips. So what we need to do is educate and empower our patients to understand what's in their food and dose adjust those enzymes so that they're confident to manage their own medication. We've got a consent for pork ingredients in our pancreatic enzyme replacement therapy. There isn't a vegetarian alternative that is effective. So people who choose not to eat pork as part of their diet, for religious reasons, for allergies, we've got to let people know that there's pork in these medications. If we've started on pancreatic enzyme replacement therapy, we've titrated, but we're not seeing any improvement in symptoms, add in a PPI. We know that acidic environments can denature those enzymes, so we change the acidic nature of the stomach, and they work more effectively. If we're still not seeing any improvement, consider an alternative PERT preparation, so move on to your second line, think about your differentials. And for people who are on enteral feed with pancreatic exocrine insufficiency, suggest using a peptide feed first line, and then add in enzymes additionally if you feel that they're still getting symptoms of malabsorption. Mary Phillips and her colleagues had really nice guidance on using powdered enzymes with enteral feeds. It's on the Consensus for the Management of Exocrine Insufficiency in the UK paper, 2021, I think. The reference is on here. Really, really useful, really nice guidance. So I'd recommend you seek that out if you have somebody with exocrine insufficiency on a feed. So in terms of management with those conditions that we've talked about today, so pancreatic cancer, PERT significantly improves survival in people with pancreatic cancer. But it's underprescribed for both people who are appropriate for surgery, but especially in people who are non-resectable. So if you have somebody with pancreatic cancer, commence pancreatic enzyme replacement therapy. Pancreatitis, so PERT is associated with improved survival in chronic pancreatitis. Now, due to the ongoing destructive nature of the disease, what's likely to happen is that you're going to increase your pancreatic enzyme replacement dose as the disease progresses. And with severe acute pancreatitis patients, some function might be regained following their episode of acute pancreatitis. So at follow-up, if they get a follow-up, this might be a nice time to test for fecal elastase to see whether they have regained any function. Now, just on this note, we looked at those diagnostic tools for diagnosing exocrine insufficiency. If you have somebody who's admitted who has a pancreatic condition, who has symptoms of malabsorption, don't use a diagnostic tool. The diagnosis of a pancreatic condition plus those symptoms is a clinical enough marker to commence pancreatic enzyme replacement therapy. So don't waste your time waiting for a fecal elastase in these patients. Use that for when we're not really expecting pancreatic exocrine insufficiency. Quality of life is hugely improved in people with pancreatic enzyme replacement therapy if they have exocrine insufficiency. So start quickly. In diabetes, we need more research into who might benefit from PERT, but if you have diagnosed exocrine insufficiency and you're starting somebody on pancreatic enzyme replacement therapy, consider the impact on glycemic control. If it was fantastic when they were malabsorbing, it's not going to be fantastic when they are absorbing. Celiac disease, minimal guidance and guidelines, but again, if you've got a diagnosis, they're using one of our diagnostic tools, commence PERT. But remember, it might be transient, so follow up, retest, see if we can reduce that pill burden. Quality of life is hugely important. For GI surgery, esophagectomy, suggest commencing enzyme replacement therapy. And for gastrectomy, think about the type of surgery. Think about our new physiology and the symptoms. There's conflicting evidence of benefit, but consider a trial and monitor. Oh, sorry, I spoke really fast. I've got 7 minutes left. So to conclude, expect the unexpected. Consider exocrine insufficiency in conditions outside of pancreatitis, pancreatic cancer. Consider if there will be a benefit from pancreatic enzyme replacement therapy. And regular monitoring for ongoing requirement and dose titration is essential.
Thank you very much. Thank you very much, Rachel. Very interesting topic. Do we want to start with some questions from the floor? So, this lady here.
Thanks for a fantastic presentation. Loved all of the detail, really well summarized. My question's a bit, when you've got that patient with persisting symptoms, how high up would you go with a Creon before starting to consider PPI, other things? I think that's always a really big challenge where you don't know, is it enough? And where would you kind of draw the line with the maximum Creon you'd give them?
In terms of the patients that I would normally see, there isn't really an upper level for enzyme dose. Which is in the guidelines. So we just kind of keep going up until symptoms are resolved. But what I would say is if we've started somebody on a dose, they're on their kind of starting dose, you know, at least 50,000, usually 75,000 for a meal, 50 for a snack, I'd probably increase a couple of times. I see them twice a week. So start them, no improvement, increase dose, see them again, increase dose. If we're not getting any improvement then, we're re-educating, we're making sure they're taking it correctly. Then I'd probably start adding in a PPI, trialing an alternative if we're not getting anywhere. And then from there, again, if we're not finding any improvement, it would be, what else is going on here? Can we look for something else? And we had a chap who was, he'd had severe acute pancreatitis, so we just kept bumping up his enzymes. And we weren't getting any improvement, did CCAT test, bile acid malabsorption. He was, you know, low-fat diet, sequestrants, he was grand. And so, yeah, it's fairly quickly is the answer.
Can I just follow on from that? I was just wondering, with the maximum doses, often doctors ask us, is there any side effects to know when you are at the maximum dosage that patients experience?
So again, because there isn't really a specified upper limit in the people that I would see, there is cystic fibrosis, because there was some reports of damage to the bowel with really high doses in children. But with the people I see, because there isn't really an upper limit, then we just kind of look at the patient's tolerance. So if somebody isn't tolerant, so if they're getting kind of gastro symptoms, you know, increased pain, increased stool movements with their enzymes, that's when we try and switch on to something else. But I've had people tell me that when they are passing a stool, it can sting quite a lot. So if it's quite stingy, that they've normally been on very high doses. And for those patients, what we've done is we've kind of pulled back. Is there any improvement, or have symptoms gotten any worse? And then if we're not making any kind of gains, again, we'll switch on to a different type and see if we're making any gains there. So that's the only one that I've ever really heard of, so stinging bum.
I think we've got time for another question. Is on there?
Hi, thank you so much for that talk. It was really interesting. You touched quite briefly on maybe using a higher amylase PERT option for people who you suspect have a higher carbohydrate malabsorption if they've got an increase in bloating and discomfort. Is that right?
Yeah.
So for the patients that you see, how often do they also have the kind of bloating and discomfort as well as the diarrhea, and how effective do you think the kind of amylase is for treating that?
So anecdotally, the people that I see, again, because there's severe acute pancreatitis and pancreatic cancer, they will often have both. So they'll have lots of steatorrhea, but they'll also have lots of bloating, feeling full very, very quickly. So they do normally have both. And that's probably for a multitude of reasons. You know, for example, if somebody has severe acute pancreatitis, if they've got any kind of necrosis or collections around the pancreas pressing on their stomach, so they feel bloated and they feel that they get full very quickly. So maybe not necessarily to do with that carbohydrate malabsorption. So I tend to see it quite a lot. But what I will do is if those symptoms are still there with that first-line enzyme, that is when I will switch to a different one and see if we're getting any improvements. It's difficult to know what the bloating is from because I kind of see it in everybody. But yes, anecdotally, I see it a lot with people, yeah. What I will say is when I do switch patients over from our first line onto our second line, and don't get me wrong, a lot of people tolerate Creon really, really well, and it works wonders for them. But if they're having some side effects, unpleasant side effects, so like increased abdominal pain, or we're not resolving their symptoms of malabsorption, when we switch them onto the new one, it actually usually tends to work quite well. So yeah, it's effective, which is great because then we're going down the route of powdered enzymes, which is difficult to manage.
I think we've got some questions from our online viewers.
Do you ever see patients with constipation rather than diarrhea? My last 3 patients diagnosed from primary care were all referred with IBS-C.
I don't necessarily see people with constipation, but constipation as a result of exocrine insufficiency can occur, but it's less common for the people that I see. Now, if they have exocrine insufficiency and constipation, what we never do is drop the dose of enzymes to get the bowel moving, because effectively we're using then malabsorption as a laxative. What we do is we continue with the current dose of pancreatic enzyme replacement therapy, and we add in some laxatives as well to keep things moving, but to ensure adequate absorption. I hope that answered the question.
And can SIBO or H. pylori infection affect fecal elastase results?
Say again?
Can SIBO or H. pylori infections affect fecal elastase results?
Ooh, not that I know of. But I cannot absolutely say no 100%. I'm afraid.
Thank you very much. I think that takes us to the end of the morning session, so I think it's time for coffee. Thank you for all our speakers today.